All right, we'll go ahead and get started on part three. This is going to cover the respiratory system of chapter seven, the human body. This should be a little bit of a quicker one. I want to do respiratory and then jump into the cardiovascular blood chapter, and then we'll keep going. But I decided to split these up to make them a little bit more bite-sized. So, first, let me say the respiratory system is very important. Like a lot of what EMS does will tie back to the respiratory system, whether it's airway management or applying oxygen or albuterol or epinephrine or whatever. A lot of emergency pathology ties back to the the respiratory system. So we do a lot of this. So it's important for us to be pretty intimate with the anatomy and the physiology of the respiratory system. It's tested outrageously heavily for the reason that we actually see a lot of this. Excuse me. Basically, the respiratory system contains all the things that contribute to respiration, right? Ventilations, right? So, the upper airway would include, so keep in mind, your airway starts like here, right? So, the nose, the mouth, the tongue, the jaw, the oral cavity, the larynx, the pharynx, right? All of that upper airway stuff. And we see pathology in all these, right? We see stuffy noses, we see swollen tongues, we see broken jaws, we see food stuck in people's oral cavities, right? We see swelling of the larynx and pharynx, right? So we see pathology related to all of these things, and that's why they want you to know what they are. But, they have a point in here, right? Sounds are created as air is forced past the vocal cords. So if you don't know, um, air comes in through your nose and mouth, obviously. And when I talk, I'm pushing air out, okay, from my lungs. And there is literally two pieces of cord, right, at your glottic opening called your vocal cords. And basically, with how tight or not these cords are, determines sound. And we use this along with our tongue and our mouth to produce words and sound. So, it's worth knowing that the vocal cords are back there, that they're real, and they have a lot to do with the production of sound. Now, again, pathology can occur back there, whether it's a viral infection or it's swelling or whatever, or they've been torn or traumatically torn or whatever. There's pathology related to the vocal cords. Okay, so it's very important to be aware of how this works in the physiology of this. The majority of this video will focus on physiology, but before we do that, let's focus on anatomy, right? So again, the upper airway, yeah, upper airway, okay? So it's going to be the nose, the mouth, the tongue, the jaw, all those are related to upper airway, okay? The pharynx back here, so like you'll hear it called the oropharynx. It's kind of like the back of the mouth, and the nasopharynx, the back of the like nasal passage. So you'll hear that a lot. The larynx is the actual like vocal cord area. And then we'll go down. So remember in the last video I was talking about the trachea. The trachea is stiff. You can feel it. You can feel this on yourself, right? It's stiff. It has cartilaginous rings through it. So basically, it keeps its shape at all times. Air passes down through the mouth, into the trachea, and then it splits right here at one of my favorite words called the carina. But my dog's name, who is Karina, is spelled the same way. I should have put a picture in here of her. She's an angel. But anyways, the carina is where the trachea will bifurcate, kind of. Well, the trachea itself doesn't bifurcate, but the main bronchus will kind of branch off at the carina. Okay, so again, that area is called the carina. That's the end of the trachea and the beginning of the bronchi where they branch off. One thing I will point out about the bronchus is if I were to stick like a wire, all right, or something like a hanger or something like that, down someone's throat, it will always go into the right side. Why is that important? If someone chokes on a piece of food or water or beer or whatever, it goes to the right lung. Almost always, there's exceptions to this based on patient position, but almost always foreign bodies will go to the right lower lobe, okay, especially if the patient was standing when it occurred. So it's worth knowing that. We run into this problem as a paramedic when you intubate someone, because you can end up sticking that tube intubation a little too far and it'll go into the right lung. So you'll just be putting air into the right lung and the left lung will not be getting air. Okay. So the apex is actually the tip. Okay. So just like the apex of a mountain or whatever, it literally means point or like tip. So the apex of the lungs is here, right? I just circled it. I'll use my little laser here. That's the apex of the lungs. This is the base, okay? So the base is the bottom, BB, right? Base is the bottom. The apex is a point. So it's the top of each lung, okay? Now, the right lung has three lobes, okay? The left lung, which is the left side, this is the right side, has two lobes. Why does the left side have two lobes? Remember, the heart does sit in the center of the chest, but a good chunk of the heart does sit a little bit more on the left side of the chest. So in order to make room for that, God said, okay, we'll just cut out a little extra lung and move it over to the right side. So the right side has three lobes, the left side has two lobes. It's worth knowing that, okay? And what is a lobe, right? They're actual, like literal, actual individual, like lobules, like sacs that are stacked on top of each other. They are interconnected to a degree, but they are individual, like sacs. So again, on the right side, we have three of those. On the left side, we have two, okay? Um, so basically, again, as air comes down through the trachea, it'll go through the carina or pass through the carina into the main bronchus and then to the bronchioles, which are smaller little air tubes, and then eventually the terminal bronchioles, and then you'll make its way to the alveoli, and that's where diffusion takes place. Okay, we're going to talk about diffusion coming up. But again, what's the muscle of breathing? There's really two. The main one is the diaphragm. That's this piece of muscle right here. It's skeletal muscle, though, and it is both voluntary and involuntary, controlled by the phrenic nerve, which is controlled by the brainstem. Okay, so those are all things that are occasionally asked. Okay, so let's look over here real quick. You've heard me talk about these grape-like clusters called the alveoli, right? So this is air coming through, right? Let me choose a different color. Air is coming through, okay? Well, what happens is air will go down into these little sacs, like keep in mind, this is microscopic, but they are little bitty sacs. And these sacs will inflate, and when they inflate, they look like a bunch of grapes, okay? Because they're really small sacs, and they inflate. And now, when they inflate, there is a capillary bed. What are capillaries? It's a junction between arteries and veins. So if I were to slice my finger and it just kind of oozes blood, that's capillary bleeding, right? So it's just a little bit of blood coming from very small blood vessels that is a junction, like a joining of arteries and veins. So what happens is these arteries and veins are so small and these sacs are so small, air, whether it be carbon dioxide or oxygen or carbon monoxide or really most gases, can diffuse through the alveolar sacs around into these capillary beds. And these capillary beds is what's dropping off CO2 and picking up oxygen. So that's where this process takes place. It's in the alveoli, within the lungs, at the capillary network, okay? So that's kind of worth knowing, okay? So we talked about this, I think, in the previous video, the thyroid cartilage and the cricothyroid membrane. Remember, you can feel this on yourself if I were to do it right now. It's right here. It's in the center of the neck. And just feel around for the hard structures, and then you'll just feel around until you feel a little dip. Don't push too hard. And that's just it's like an opening in this like tough cartilage. And sometimes we'll shove a tube through there as paramedics um, to if like someone has like an obstruction but in their upper airway. So we'll cut that with a scalpel and shove a tube through there. So it becomes kind of relevant, you know. So the lower airway now will contain the trachea, the bronchial tree, the alveoli, and the lungs. Why am I reading that to you? Because they could ask you that. Which of the following is part of the upper airway and the lower airway? Use your process of elimination, read all the answer choices, and it's pretty intuitive if you know where these structures are located. Okay? So gas exchange occurs in the lower airway. I will say gas exchange only actually I want to be technical. Gas exchange only happens in the alveoli. I'll say that again. True gas exchange does happen in the lower airways. It does, but it only actually occurs in the alveoli. These guys, that's the only place it truly occurs, okay? Everywhere else is this thing called dead space, okay? Literal dead space. Because yes, air is going through there, there's blood there, but gas exchange does not take place there, okay? Gas exchange takes place in the grape-like clusters that we're calling the alveoli, okay? A single name of one, like one alveoli, is called an alveolus. Now, the lungs themselves are surrounded by this uh, um, pleura. And what pleura is it's like this, it's thin. Let me start with that. And it helps, in there, there's this pleural fluid. And what pleural fluid does is it lubricates because, as you can imagine, as you're breathing in and out all day, if there was no lube there, it would start to rub. And as it would rub, it would eventually rub a hole in itself. And there's pathology called pleurisy where we don't have pleural fluid. And so then we can end up with pleurisy, which when you listen with your stethoscope, it literally sounds like rubbing when you're listening to their lungs. It's real weird. And it hurts. Obviously, it'll hurt the patient. But this picture is a good, so know that pleural fluid exists, and we have this thing called visceral and parietal pleura, okay? Um, Parietal pleura, it goes around the outside, and visceral pleura is the inside, okay? Um, there's this thing, it may help you, called visceral fat. Visceral fat's the fat up inside your guts, like in the inside of your organs. And so I just remember like the visceral is more inside. Might help you, might not. Okay. Now, um, this is the patient's left and this is the patient's right. How do I know that? Because I'm looking at them. So most time when you look at anatomy, you assume you're looking at the interior view. But anyways, I know it's also the left and right because I just told you the patient's right side has 3 lobes, the left side has 2 lobes. Okay. Um, Now with this, I want to point out because I don't want to confuse you. It's not like you're going to listen to their lobes and be like, "Oh yeah, that's definitely the right upper lobe and right middle and right lower." Yeah, that really doesn't happen because the same could be said over here. You could listen here and here and here and here and here and here, right? And it doesn't really matter. I'm just letting you know that the left side has 2 lobes, okay? Now, the primary muscles of breathing are the diaphragm. Remember, when muscles contract, okay, they get smaller. And the diaphragm normally sits in like a dome-like fashion because your guts are pushing up on it. So what happens is when you breathe, when you contract that muscle known as the diaphragm, which is skeletal muscle, it will flatten out because muscles get smaller when they contract. And as it flattens out, it's like pulling the back on a syringe. You're causing a negative pressure. So it sucks air in through the mouth and nose. And then as you breathe out, which is a passive process, exhalation is passive, that goes back up into a dome shape and it pushes air back out. So that's the main muscle of respiration, ventilations, okay? Yes. But there is the second thing called the intercostal muscles. What are the intercostal spaces? I'm glad you asked. It's these rib thingies. Remember, you can feel this on yourself. It's the meat between the ribs, okay? So there's actual muscle there. And so what happens is, yes, we typically just use our diaphragm for breathing, like as I'm giving this lecture. But say I have a disorder like asthma or chronic obstructive pulmonary disease or emphysema or bronchitis, blah, blah, blah. Um, we our diaphragm can get tired, and so we can end up using what's called accessory muscle usage, and we can end up using our diaphragm and then our intercostal muscles, right, the muscles between our ribs, can kind of join in to help. The reason this becomes relevant is because clinically, if you see a patient that has accessory muscle usage, right, they're breathing and they're having a hard time, and you see their intercostal muscles really working, it's ominous, right? It's a sign that that patient is sick. That patient needs intervention. That patient needs to go to the hospital. You need to treat them. It's a bad thing when that happens, and it actually happens a lot. You will see this. Okay. Um, I'll quickly point out that of course the vena cava and aorta and the esophagus, right, the food tube behind our trachea, where we swallow food, they all punch through the diaphragm down into the guts. Okay. Um, and that's pretty much what I want you to know about that. Okay. Um, so again, gas exchange, just like that picture I showed you, it takes place at the capillary membrane network within the alveoli, which is the lower airways. That's where it takes place. Not in the trachea, not in the bronchus, not in the mouth, not in the nose. No gas exchange. Okay? It takes place in the capillary network within the alveoli. Okay? And again, the act of getting air in and out is ventilation. The act of diffusion is called respiration, and then cellular respiration is a whole. We talked about that in the first part. But diffusion, we've talked about this. It's like the Axe body spray or someone ripping farts, right? So they rip a fart, right, in this corner of the classroom, and it's at a high area of concentration of smelly farts, and then it's going to go to an area of low concentration across the room to you. That's diffusion. The same thing is happening in the lungs, and I'll show you here, okay? And at the cellular level. Let's start with the cellular level, which is this half, okay? This half. Um, so what happens is the cells do their job, okay? And as a cell does its job, it releases CO2, okay? And CO2 will build up in a higher, relatively higher concentration around that cell compared to oxygen, okay? So what happens is the capillaries, these things, will end up bringing dissolved oxygen. It's really, it's better to say that it's bound to red blood cells at the hemoglobin, but sure, dissolved into the cells. Okay, why is that? Because of diffusion. What does diffusion say? An area of high concentration to low concentration. Well, in the blood, we have a high concentration of oxygen compared to these cells have a low area of or a low concentration of oxygen. So what happens is you end up dropping off your oxygen from high concentration to low concentration, and the CO2 is building up and the concentration is increasing, so you end up picking up CO2. But CO2 is actually dissolved in the plasma. It doesn't for the most part bind to red blood cells, okay? What's plasma? It's the clear stuff in your blood. It's kind of like the yellowish color stuff in your blood. It's like a liquid, okay? So the plasma will pick up the CO2, right? Carbonic anhydrase takes place, right? And then boom, it goes back up to the lungs, okay? So I'm going to recapitulate that because you got to know this, okay? Your oxygenated blood, right? Bound to red blood cells is oxygen, O2, okay? It goes down to the lung or to the tissues, and the tissues say, oh, wow, I don't have a lot of oxygen. I'll take that. Diffusion takes place, simple diffusion. And the oxygen will be dropped off at that hungry cell because the concentration there is less than what it is in the blood, diffusion. And then after the cells do their job, cellular respiration, right, Krebs cycle, then it'll pick up the CO2 because there's more CO2 within the cells and bind it to the plasma in the blood because there's less CO2 in the plasma in the blood. And then it makes its way to the heart, and through the heart, we're going to go to the lungs next, okay? I hope that makes sense. Now, at the heart, it travels through the right side of the heart to where it eventually ends up in the pulmonary artery, okay? At the pulmonary artery, it's going to start shunning its way down to these capillary beds around the alveoli. Remember, alveoli are the little grape-like structures. So what happens is, in these capillary beds, diffusion takes place, but it's a little bit different now. We have a higher concentration in this venous blood. This blood is quite literally purple-bluish, okay? Higher concentration of CO2, okay, bound to the plasma. The book's wrong here. And it's bound to the plasma, and now it is at a higher concentration in the venous blood than what we're breathing in through the ambient air that's sitting in your alveoli. So what happens? It trades off. High concentration in the blood, low concentration in the air that we're breathing in, diffusion takes place, on to the next guy. So that's how that happens. And conveniently, at the same time, we have a higher amount of oxygen in the air that we're breathing in. So oxygen gets shot back into the blood, and then now the blood turns red. So when blood is oxygenated, it literally turns red. When blood is deoxygenated, it literally will have a purplish, bluish color to it, okay? The reason of that is oxygen concentration, okay? You've probably seen this at the doctor's office. If they draw your blood, it's usually purple, right? That's because it's venous blood. It's deoxygenated. The cells have already used up all the oxygen and loaded it up with CO2. Conversely, if you slice your finger and it turns bright red, it was exposed to the oxygen in the air that we're breathing, so it turns red. It oxidizes, okay? Well, the hemoglobin gets bound and it's a color change, but yeah. All right, so this crazy high yield. If it doesn't make sense, do not go any further. You need to watch YouTube videos. Email me, Jeff, Laura, someone, and say, I need help with this. If you don't understand this, we're in trouble. You got to know this. Don't think, oh, I'll skip past that. I'll figure that one out later. No, you won't. You need to know this. It's very, very important. It's tested a lot. Okay? Now, I would ask you, student, what controls you to breathe? Is it low oxygen? No. Is it high CO2, carbon dioxide? Yes, it is. So what controls us to breathe? And this is interesting. It's probably contrary to what John Q. Public thinks, right? What controls us to breathe, what says, hey, brain, you should breathe a little. It's carbon dioxide. It's not oxygen. I will say that again. The main respiratory stimulus is accumulation of carbon dioxide in the blood. Where did the carbon dioxide come from? Oh, cellular respiration, Krebs cycle, TCA cycle, citric acid cycle. It came from there. It came from cells doing their job. Okay? And consequently, CO2, I'll write this for you. CO2 equals acid. CO2 is acidic, very acidic. Not very, but it's acidic, okay? So CO2 is acidic. So you got to know that, and it'll make sense in just a minute. So with that said, that is the main way that we normal people breathe is high CO2 in the blood. Excuse me. Makes its way over to the brainstem. The brainstem well, there's several places this is sampled, but mainly the brainstem, and it'll say, breathe faster, get rid of the CO2. That's what it's saying. It's not saying breathe faster, you need oxygen. It's saying breathe faster, you have too much CO2. That's what stimulates breathing. Now, with that said, we could occasionally, in certain pathologies, have low blood oxygen to stimulate breathing. But this takes place peripherally. It does not take place in the brainstem. Quite literally peripherally, like not in the brainstem, other places, other chemoreceptors, okay? So where we see this, I hate that your book even mentions this because it's an exception, not the rule, is in COPD in a condition called hypoxic drive. Oh, and it's on the slide, right? So these two are together. So let me highlight these two in the same color because I don't want you all to get confused. So low blood oxygen levels will stimulate you to breathe when the normal system has failed. Where does this happen? I'll tell you. In a disorder called chronic obstructive pulmonary disease. Who gets chronic obstructive pulmonary disease? People that smoke cigarettes. Yeah. So people that smoke cigarettes, they always have too much CO2 because their lungs are destroyed. So what happens is they end up retaining so much CO2, the brainstem says, I don't know what to do. I always have too much CO2, and if I breathe too much, these things get out of whack. So what happens is a different part of the brain will say, aha, we have too much CO2, and it's not working. So what if we just breathe on low oxygen? That's hypoxic drive. What's hypoxia? Hypo, low, oxygen, oxygen, right? So low oxygen drive. So that's called hypoxic drive. Why is this clinically relevant? Because there used to be a theory, although it's not true, that it's not true for EMS. There used to be this theory that is not true for EMS that said if you give a patient who's living on hypoxic drive, who probably has chronic obstructive pulmonary disease, smokes cigarettes, if you give that patient a bunch of oxygen, and when they get a bunch of oxygen in their blood, their brain, or really their periphery, would say, we don't need to breathe anymore. And that can happen in the long-term setting. It only takes place in like the ICU. It will never happen on your ambulance. But that's a whole nother story. We'll get into the respiratory chapter later. But I'm laying a foundation here. It's important to know these things. So I'll say this one more time. What is our normal mechanism of breathing? It's high CO2, high carbon dioxide. What now? There is an exception. There's this thing called the hypoxic drive. Hypoxic drive is for people that smoked for a long period of time, jacked up their lungs. They end up holding up too much CO2, and so their brain doesn't know a high, low CO2 anymore. It's not sure, so it reverts to this thing from our peripheral chemoreceptors that say, we'll just live off hypoxic drive. That's enough for that moving forward. Now, pH scale, you should know this. What is the pH scale, right? It's an inverse logarithmic scale of hydrogen molecules, okay? So oddly enough, the more hydrogen molecules there are, think hydrogen equals acid, okay? Because it does. What happens is the more hydrogen we have, the more acidic stuff gets. So oddly enough, the more hydrogen we have, the pH scale goes down. Again, inversely logarithmic, okay? It's inverted. So again, the more acidic something is, the lower the number will be, okay? So like lemon juice, very acidic, pH is 2, okay? Now, the opposite could be said with a base, okay? So we know that pure water is like a 7, okay? Now, the opposite could be said with, with uh, something that's basic. So basic means that it has less hydrogen ions. So if something has less hydrogen ions, it's less acidic, and it goes that way on the periodic table, or I'm sorry, the pH scale. So something that's really basic would be like ammonia, bleach, lye, stuff, baking soda, stuff like that. Okay, so that's kind of what I want you to know. And here's how this is tested. Write this down. The normal pH in the blood is 7.35 to 7.45. You got to know that. 7.35 to 7.45 is the normal pH in human blood. Why is this relevant? Well, remember me telling you that CO2 is acidic, because it is. Well, what happens is what's really stimulating us to breathe is acidity, not entirely just the CO2. It's the acidic effect that CO2 has on our pH of our blood. So here's how this happens. What happens is as CO2 builds up in our blood, which is acidic, our blood becomes more acidic. So acidic blood is going to have a pH more or less than 7.35. Less. So it's going to go this way. Okay, so let's just say you have a patient that's not breathing at all. Right? They overdosed on morphine, okay? They're breathing 2 times a minute. So they're not blowing off CO2. So here's how this happens. They're not blowing off CO2. The CO2 is acidic. It builds up in their blood. It drops their pH because their blood becomes more acidic, okay? So their pH could drop to like 7.28, okay? Now, this is what's interesting. Someone's pH less than probably, I used to know the number, 7.15, they're probably going to die, okay? More than likely, definitely less than 7.1, it's over, their kidneys are shot, they're probably going to die. So you think to yourself like, oh, like crap, that's a lot of, it's a very narrow index. You're right, it is. So the brain and the respiratory system and the kidneys are working really tightly to keep the pH of the blood intact, okay? Because if it gets too low too quick, the patient will die. Like invariably, they're going to die. There's a lot of reasons why they die. But just know that you can't have a pH of 6. It just doesn't happen. You might get a pH of 7 if you go into cardiac arrest and we check it, but it's not looking good. Not looking good when that happens. Okay? Now, here's how this happens. Moving on. Inversely, right? So let's just say you failed your exam and you start hyperventilating. So what do we do when we overventilate? To breathe, right? So when we overbreathe, we're blowing off too much CO2. Okay? So as we're blowing off too much CO2, which is acidic, we have less acidic stuff in our blood. So the pH will raise. Our blood will become basic. It becomes less acidic. So the pH, which at the highest end of normal would be 7.45, might go up to like 7.52. Oh, that's bad, right? So again, you can't get someone's pH up to like 7.7 and expect them to live. It just doesn't happen. They're going to die. It really never happens. But just know that's, the clinical relevance of this. This whole low pH, high pH. It has to do with how fast is the patient breathing? Are they holding on to CO2? Are they getting rid of CO2 too rapidly? Where does that influence? It's this big dogma of what stimulates humans to breathe, okay? Now, moving forward, we have this thing called the buffer system, okay? And basically what it does is it tries to neutralize these acids and bases to keep our pH in that really narrow index of 7.35 to 7.45, okay? That's the pH. So, of blood. So what happens is we have mainly 2 ways that the humans can fix this, okay? The first way that I want you as an EMT to think, the quickest way to fix the pH of your blood is through your lungs. Through your lungs, okay? So if someone has a buildup of CO2 in their body and I need to get rid of it really quick as an EMT, guess what I do for them? I breathe for them faster because I end up blowing off CO2. And when I blow off CO2, which is acidic, I end up raising the pH of their blood so their blood's less acidic, more basic. I can get it back to normal quicker, okay? And how quick can I breathe, change the respiratory rate of a human? Very quickly, seconds. I can start bagging them, squeezing like on the movies, like the BVM, really quickly, and I can get rid of CO2 by breathing really fastly, okay? Now, there is a second system that is vital, but it's slow. It's slower than Christmas. It's very slow. And it takes about, it depends who you ask. Let me change colors. It takes like 12 to 24 hours. It really depends on who you ask. It takes longer than instantaneous, which we can do with the respiratory system. So I want you to think 12, 24 hours for the kidneys to really kick in and really go to town, right? And do what they're supposed to do. But the kidneys can excrete hydrogen through the urine, one, and two, they release this thing called sodium bicarbonate. Okay, and sodium bicarbonate is a buffer. What does sodium bicarbonate do? It finds hydrogen in the blood and it buffers it. It like wraps its arms around this little stinky hydrogen molecule and says, you ain't going to be acidic no more. So what happens is, if it can't be acidic anymore, then uh, it'll raise the pH of the blood. It makes it more basic because you just took that hydrogen boy out. It's out. Can't be used. So who releases sodium bicarbonate? It's the kidneys. How long does it take? Hours, days. Okay? Who's the quickest one? Who's the first one that can react? It's the lungs. If you don't believe me, go run to the end of your street and back as fast as you can. What are you going to do to get rid of the CO2? Are your kidneys going to kick in? No, you're going to breathe really hard and really fast. It's called Kussmaul respirations. Sounds sophisticated. And that's why you have too much CO2 from all your muscles doing their little Krebs cycle thingy. Okay? So very important dogma to understand this, okay? Now, this is annoying. We have this thing called the ion shift. I think this is a little advanced for EMT school, but I'll explain it quickly. So, um, I explained the whole hydrogen and hydroxide. This is hydroxide stuff. Okay, that's superoxide. I'm sorry. What I need to talk about is this bottom one. Sometimes we can get, and really it's a chloride shift. Let me see to make. Yeah, I've explained this. This actually isn't what I thought it was going to say. I apologize. There's this ion shift. I would be shook to my core if you were tested on this. Okay, I don't think this is high yield. Moving forward, there's I just explained this. The three components of the buffer system. Remember, the first one to the seam, numero uno, is the respiratory system. You can control your respiratory rate like that. It can change. What takes hours to days to change is the bicarbonate buffer system, which this comes from your kidneys, and the renal component. Remember, dumping acid in your urine and other stuff in your urine. This is the kidneys. Okay, it takes a while for this to happen. So first one to the scene is always the lungs. It's the respiratory system. The last guy to the party is the stinking kidneys. They take a long time, but they're really helpful. Good guys. They're just always late. So just be aware of that. Now, the nervous system does control breathing normally. And where does that take place? The medulla oblongata of Waterboy, alligators max, they got on them teeth and no toothbrush. With Colonel Sanders? No? Okay. Anyways, it's the medulla oblongata, and it's a part of your brainstem, okay? And basically, and I have it right here. Basically, it's the primary area responsible of the brain for initiating the ventilation cycle. And what drives this? It's too much CO2, which drops the pH of the blood because the blood becomes more acidic. I know that's a lot, up, down, blah, 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 blah. But I'll say it again. What stimulates breathing normally in a normal person? It's at the medulla oblongata, which is in the brainstem. You got to say it like the water boy. And it stimulates the ventilation cycle because there is too much CO2. The pH is lowered because it is more acidic. Weird, I know, up, down, but you have to know that, okay? Now, this next part is a little complex. There's videos all over YouTube on this. I will do my best, but there's a lot to this, okay? So, let's talk about it. Do you know what a tidal wave is? You ever look at the ocean and watch waves? They're just tidal waves, okay? Well, interestingly, when we breathe, our pattern, if you were to look at it, it's tidal. It looks like a wave, right? Oh, and that's what they're showing you here. Let me use my laser for this one. Laser beams. All right, there. So what happens is um, this is a normal breath in and a normal breath out and a normal breath in and a normal breath out. And what that amount is usually around 500 milliliters. How much is a 500 milliliters? It's half my water bottle. It's a normal water bottle. This is a liter. So it's about a normal water bottle is what you're normally breathing in and out. Normal things when you're not really thinking about breathing. It's around 500 milliliters, okay, which is about a normal size like a Zarka water bottle. So that's the tidal volume. So that's the amount of air moved in and out of the lung in a single breath. You will see these on exams and quizzes. It is coming. Spoiler alert, you're gonna see this. Okay, what's the tidal volume? And they're gonna have a bunch of definitions. You're gonna have to pick the right one. Okay, it's the amount of air moved in and out of the lungs in a single breath, normal breath. Okay, I should say normal breath, compared to the inspiratory reserve volume is the deepest breath you can take after a normal breath. So with me, we're gonna look like fools and do this. Is you're gonna take a breath in, right? And I'm inspiring as deep as I can go. And that's the deepest breath that I can get. How much did I just suck in? About three of these puppies. 3 liters, 3,000 milliliters is what I just sucked in, okay? That's a lot of air. So again, the inspiratory reserve. So it's just reserved, right? You don't really need this, right? That's a lot of air that I just sucked into my lungs, okay? It kind of hurts. So that's your inspiratory reserve volume, okay? And that's being shown here on this little graph. I wouldn't spend a lot of time memorizing this. I just put this for the visual learners, okay? And then let me, yeah, we'll do this. And then let me just drop this picture on here. Pardon me. There we go. And then we have the expiratory reserve volume. So what is this? This is the maximum amount of air that you can forcibly breathe out after a normal breath. So let's do it, right? So breathe in, breathe out, right? That's your expiratory reserve volume. It's the amount of air that I normally have in my air or have in my chest that I have control over breathing out. And that's around 1,200 milliliters, okay, or 1.2 liters, okay? Decent amount of air, all right? But no matter how hard you try, you can't blow every last drop of air out of your lungs. We have this thing called residual volume. What's residual volume? It's the amount of air and I breathe out and I shoot all the air out again. There's still some air in my lungs. And that residual air is the residual volume. Okay? How much is in there? 1,200 again. 1,200 milliliters left in there. I cannot get it out. Even if I want to, I have no control over it. Why is it in there? It's keeping those little alveoli open. And then lastly, there's this thing called vital capacity. What's vital capacity? Last exercise, don't pass out on me. Here's how it goes. So it's the greatest amount of air that you can move with a maximum inspiration, maximum exhalation. So let's do it. Okay, this is your vital capacity. It's vital you do this. So that's vital capacity. How much is that? I think it's around 5 liters. Does it say? Yeah, it's usually around 5 liters. Okay, so 5,000 milliliters. It's a lot of air. Okay, it's 5 of these big water bottles. Okay, 5 liters. All right, moving forward. We're almost done. Hang with me. Getting to the end of this. Now, I told you about these dead space things. Remember, dead space is the mouth, the nose, the trachea, the bronchi, the bronchioles, everywhere but the alveoli. Okay? Because gas exchange does not take place there. So simple test question, right? The question's going to say, which of the following is dead space? Anything that's not the alveoli is dead space. Easy. But don't get caught on the shenanigans that the test writer is going to do to you. So what's dead space? Anything that is not the alveoli. That's dead space. Why is it dead? Because gas exchange does not occur there. Okay? Minute volume. This is the amount of air that's breathed in and out in 1 minute minus the dead space. What does this look like? You don't need to memorize this. So let's just say I told you the normal tidal volume is 500 milliliters. And let's just say I don't know. I'm a little anxious guy. I breathe 20 times a minute. So this is your frequency. So how many times you're breathing a minute. So what's 500 times 20? I think that's 10,000. Okay. So here's an interesting formula. I have to subtract my dead space. Dead space, I think I should have looked this up, is around 150 milliliters per breath. So here's how this formula would actually work. It's going to be 350 because I got to take, let me just do this all drawn out. You got to subtract the dead space. That's 350 times 20. I'm not a math major, forgive me. 7,000. So I'm breathing 7,000 milliliters a minute. That's minute volume. It is tidal volume times frequency minus the dead space. I'm pretty sure, I'll make an addendum if it's wrong, but I'm pretty sure dead space varies on people. It's around 150 milliliters of air. So what does that 150 come from? It's saying when I take a breath in, of that 500 that I'm breathing in normal tidal volume, 150 of it is dead in the dead space because it's not making its way to the alveoli for gas exchange. So only around 350 is actually making its way to the alveoli for good old gas exchange to take place. All right. Characteristics of normal breathing, intuitive. We've all been here, right? Normal rate and depth, regular rhythm, good audible. Audible is something you can hear. Breath sounds on both sides of the chest. Regular chest rise and fall on both sides of the chest. It should be symmetrical. Movement of the abdomen. That can be pathological, but sure, you might have a little bit of movement of the abdomen, especially. Okay, you see movement of the abdomen in pathology, really. That's accessory muscle usage, by the way. So, I don't know about this one, but who am I? I'm not writing your test. So, that's it for this video. This one was a little quicker. Next one, we're doing cardiovascular. I appreciate y'all's attention.